So it's a great pleasure to have Dr. Uday Popat, who does not need any introduction for these
Just a
audiences.
wait, sir. Just a moment, sir. We're good to go.
Yeah, perfect. So it's a great pleasure to have Dr. Uday Popat, who does not need any introduction to our Indian community. He has been phenomenally successful and helping us as transplanters to grow in past 1 decade. We have grown and become what we are doing today after listening to his many of his talks in various forums in the country. And thanks to Dr. Uday Popat for joining us today in this webinar series, which is not only being attended by Indian audiences, but across the world, from West Indies to Myanmar to Mongolia. So it's a great pleasure. And Dr. Nikhil has done a phenomenal job, and Dr. Srinidhi also has joined in as geneticist, who has got access to NGS MRD. And NGS MRD has actually shown us the new pathways for understanding of disease, disappearance of each and individual mutations. So with with this, I will hand over to Dr. Nikhil to start the proceedings. Thank you.
Thank you, Dr. Bhargav, for that kind introduction. Welcome everyone to yet another session in the Innovations in Hematology series. This is a monthly webinar series, which is more than 1 year old now. Every month, we try to answer one clinical question, which is often challenging, and we try and get an international expert on the field to understand the complexities of the subject and how we can best improve clinical practice. So we have a lecture of around 40 minutes duration, followed by a question and answer session for which people from across the country have contributed the questions which we would like to ask the subject expert. So today we have Dr. Uday Popat with us. He doesn't need any introduction to the hematology audience. He is a professor in the Department of Stem Cell Transplantation at the prestigious MD Anderson. He would be speaking to us regarding therapeutic strategies to prevent relapse in AML post-transplant. With improvement in supportive care, more and more patients, even elderly patients, are able to undergo transplant in India today. And a large chunk of these patients are acute myeloid leukemia patients. With better medications available for supportive care, good GVHD prophylaxis, the transplant-related mortality at our center and as well as many other centers have dropped to less than 10%. With patients living longer, we are seeing relapses both in the early as well as late post-transplant period. We have patients who come back after 2 years, 3 years also with late relapses. And at the other end of the spectrum, we have patients who relapse very, very quickly after becoming MRD positive. So every time a patient relapses, we have many questions. Why did this happen? Could we have predicted this better? How does pre-transplant disease control affect the post-transplant outcomes? What is the role of maintenance strategies post-transplant to reduce the risk of relapses? How quickly should we taper immunosuppression to reduce relapses in high-risk transplant? And many more questions. We hope that today's discussion would throw light on this topic and help us to manage our post-transplant patients better. Dr. Uday Popat is a professor of medicine at the Department of Stem Cell Transplantation and Cellular Therapy at the MD Anderson Cancer Center, Houston, Texas. He did his early training, including medical school in Mumbai, and received further training in hematology, medical oncology, and stem cell transplantation at multiple teaching institutes in the UK and US, including Baylor College of Medicine and the University of Texas MD Anderson Cancer Center. Currently, he is working as a professor in the Department of Stem Cell Transplantation. He is also the interim deputy chair of the Department of Stem Cell Transplantation. Dr. Popat's research interest includes development of novel conditioning regimens for transplantation, improving transplant outcomes in older patients, and transplantation in myeloid malignancies and autoimmune diseases. He has published extensively in peer-reviewed international journals of repute, and it's my pleasure to welcome Dr. Uday Popat, who has extensive experience in the field of stem cell transplantation, to speak to us on this topic. Before I hand over the session to Dr. Uday, I would like to introduce our speaker for the next webinar, which would be on the 27th of June. Shifting gears from malignant hematology, we would be having a webinar on a very interesting topic in benign hematology, where we would address a case-based discussion in therapeutic anticoagulation, where Dr. Alok Khurana from the Cleveland Clinic would be speaking to us on challenging scenarios in therapeutic anticoagulation. We are familiar with Dr. Khurana through the Khurana score to predict the risk of thrombosis in malignancy. And we would welcome all of you for the next month's webinar also. This is our team at Fortis Institute of Blood Disorders, where we are a group of 15 doctors, including pediatric, adult hematologists, geneticists, intensive care hematologists, nutritionists, nursing practitioners. So this big team enables us to do more than 200 to 250 transplants every year. And like every other center, we would love to hear from Dr. Popat regarding how can we best handle our post-transplant patient and reduce the risk of relapse, which ultimately is the main challenge that we are facing as a transplantation unit. Patients coming in with relapse at various stages, both early and late in transplant. So I'll stop sharing my screen and I'll hand over the section to Dr. Uday Popat. He would be speaking us on strategies to reduce relapse post-transplant in acute myeloid leukemia patients. Over to you, Dr. Uday.
Thank you for that very kind introduction, Dr. Bhargav and Dr. Nikhil Kumar. Whenever I get an email from Dr. Nikhil Kumar, it makes me worried. I said, okay, now I need to get my act together, get the data together for this presentation, because his questions are very precise and so it is a great effort, and in fact it is a great learning opportunity for me as well, because I myself then sit and look at my own knowledge, if you will, and question it. So can you see my screen?
Yes, your screen is visible and you're audible.
Okay. So without further ado, my topic today is strategies to reduce relapse in acute myeloid leukemia. And before this webinar began, and I was having conversation with Dr. Bhargav, and really the thought or the idea that I mentioned was what is difficult for you is also difficult for everybody and all of us. Even in West, with all the sophisticated technology available at our disposal. As I'll show you in our data, relapse is a major cause for treatment failure. We'll briefly talk about risk factors for relapse. And then we go on to strategies that are being adopted, including some novel strategies, some data fresh off the last ASH meeting and ASTCT meeting, our own and some other centers, and give you some insight into what data that is out there and what approaches people are taking. So relapse remains the leading cause of mortality after allogeneic transplant. And as you can see over here, about half to 60% of the patients fail because of relapse. And this is the data from CIBMTR. And as you can see, the largest pie of this curve is the one which shows that it is relapse. And once a patient relapses, the outcome is very poor. So as Dr. Kumar and Dr. Bhargav mentioned, relapse remains a major problem worldwide. So when you think about relapse, and if you think this is a problem, then the question really is, what are the risk factors? And maybe if you know why relapse is happening, what are the risk factors? And here are some of the clinical risk factors. And if you know this and if you can fix them, maybe you can improve the outcome. So first and foremost are genetic risk factors. So if you can see in the top left curve, adverse ELN cytogenetics, the relapse rate is 40%. And if you choose TP53 positive patient, then this goes up even higher. 65% of these patients are going to relapse. In fact, we really don't have good treatment for TP53 positive disease. The other marker is the remission status, and patients who are not in remission do poorly. So as you can see in the bottom left curve over here, patients who have either active disease or who are minimal, who have measurable residual disease. We used to call it minimal residual disease, but now we call it measurable residual disease. They have a high relapse rate of 65%. So I guess the first, you cannot do anything about genetic risk factors because that's what your patient has, but you can certainly try and reduce incidence of this by using better effective chemotherapy. And one classic example is use of targeted agents which have improved remission rate and which have improved MRD positive rate and which have improved outcomes. Classic case in point here is FLT3 inhibitors or use of venetoclax in induction therapy. So some of those advances are percolating through, and I'm sure in your center also you are using many of these agents. But if you can get these patients into remission, then your outcomes, your relapse rate certainly goes down. A second thing, which is that other than induction therapy that is in our hand as doctors, is what is the intensity of conditioning that we can deliver. And this is a seminal BMT-CTN trial, which did show that relapse rate with reduced intensity transplant is much higher than myeloablative. So this was a randomized study, and if you could get reduced intensity, patients were eligible to receive either reduced intensity or myeloablative regimen. And it turns out that reduced intensity was associated with very high relapse rate, and that translated into better survival, both overall and relapse-free survival. So the point here is dose intensity is important. And if you can, as a transplant doctor, deliver higher intensity, that would be better. But a particular challenge, therefore, is illustrated in this thing. As a transplant doctor, we control induction therapy, and there are many advances, and I will not go over this. I'll go over what, as a transplant doctor, we can control, and that is conditioning regimen and the maintenance therapy that our patients get. Improvement in supportive care has led to reduction in survival, and I'm so glad to hear that everywhere the non-relapse mortality is going down, and your center has a fantastic non-relapse mortality rate of 10% or less. So the question is, how do you deliver high intensity conditioning in patients who can only tolerate reduced intensity regimen? So in other words, patients who are older and infirm, can you give high intensity conditioning? So here is something that we started studying, and this was in myelofibrosis, but I think the principles here are very effective because this taught us a lot. And what we did in this was, we started with standard Buflu-2 reduced intensity regimen where they got 2 days of busulfan and fludarabine. And these were patients with myelofibrosis. Median age was in 60s. And initially, when we started this study in 2005, the question was, can we get this patient to engraft? And we were very happy. We could get them to engraft. Our non-relapse mortality was very low, even in patients as old as 65, 70. But a year down the line, And this is a side that says sin. When you get that bone marrow result, that patient has relapsed. So out of our first 12 patients, 5 relapsed in early analysis. So we said, what can we do? So certainly this myeloablative, this reduced intensity regimen is resulting in higher relapse rate. Could we intensify the regimen? And this is where the use of pharmacokinetic analysis comes in. And the principle here is very simple. If you give a dose of busulfan in a patient, you get this Gaussian distribution. So if you were to test, some patients will get higher systemic drug exposure, which is on this x-axis. Some patients with the same dose will get lower drug exposure. Now, when you get high drug exposures, you get higher toxicity. If you get low drug exposure, the relapse rate is higher. Wouldn't it be ideal if we could get appropriate drug exposure in this sort of a form just below the toxic level, or so just near the safe limit? And we do this by giving them a small test dose of busulfan. We measure the levels. We determine the pharmacokinetics, how the drug is metabolized and distributed. And based on the calculated half-life and area under the curve, then you go backwards and dose the patient so that you can get a targeted exposure. So what you're getting is kind of a finite PK-guided dosing over here. And it turns out that you can give on an average, pretty high dose. And in this study, subsequent 30 patients, we ended up giving 12.3 milligram per kilo, but this was pharmacokinetically guided. So some patient got lower, less, and some patient got more. And this was older patient, median age was 58. And what we found was when you escalate the dose, now area under the curve 16,000, implies that this is 80% of the myeloablative dose. Myeloablative 4-day fludarabine and busulfan, 4 days of busulfan will give you area under the curve 20%, 20,000. And this one is 16,000. So this is 80% of the myeloablative dose. And what we saw was a 3-year relapse rate came down from 53% to 32%. And that translated into better event-free survival. And so the principle here was that by giving pharmacokinetic dosing, we could improve outcomes. So we took this to AML and MDS. We did a randomized trial. And some of you can look at this. And this was in Bone Marrow Transplant, published in 2017. We had 225 patients with AML and MDS. Patients either got fixed dose, 130 milligrams per meter square of busulfan and fludarabine, or they got PK guided the way I showed. And we targeted, this was a myeloablative regimen, so we targeted area under the curve 24,000. And what you can see here is this translated into better overall and event-free survival. This was a randomized trial. And we saw actually, interestingly, reduction in both treatment-related mortality and relapse rate with this regimen. And I think since then, for us, all our patients who get busulfan get this pharmacokinetic dosed treatment. So intensifying busulfan with pharmacokinetic guidance will appears to reduce relapse. This was idea number 1. So next step was what else can you do? So this is the second principle that we came across or we discovered. And here is that you can reduce the toxicity and mortality of intense regimen by simply giving it over a longer period. And so because there is a critical need for developing a conditioning regimen that reduces the risk of relapse without increasing non-relapse mortality. The second part is very important. You can give very ablative dose of radiation or busulfan, but if that causes very high treatment-related mortality, eventual outcome is not good. So you need to not allow NRM or non-relapse mortality to go up. So if this was the regimen that we were using 4 days with pharmacokinetic dosing, what we said was let's give a third of the dose, and this is busulfan of 80 milligram per meter square on day minus 13 and 12. We do pharmacokinetic analysis with this dose, and then give rest of the dose so we can target area under the curve 16,000, which is 80% dose, or 20,000. And when we randomize the patient, and the patients who were eligible for this trial were patients who were candidate for reduced intensity transplant. So instead of reduced intensity transplant, we would give them this particular version of treatment. And our primary endpoint in this study, this we started in 2012, was non-relapse mortality. And this was, again, this for older patient, median age was 62 and 57. There were many patients in their 70s, actually, about 10% of these patients. And they had high comorbidity, as you can see at the bottom. And what we saw was this was very well tolerated. And our 100-day mortality was 4%, whether they got 16,000 or 20,000. So what we then demonstrate here is by simply fractionating the busulfan, it's a very simple idea. We are now able to give myeloablative dose of busulfan to frail and older patients without increasing non-relapse mortality. And then the question is, does it actually reduce relapse rate? So we compared the patients who got this myeloablative dose of area under the curve 20,000 to our standard 4-day regimen. So we compared this fractionated regimen with myeloablative busulfan with low dose regimen, and this was not a randomized trial, but that was a matched cohort study. And what we find here is the relapse rate, 2-year relapse rate, significantly goes down from 59% to 34% without much change in the non-relapse mortality. As you can see, and these were, again, older patients. The median age here was 65 years and 66 years. So really the idea is that you can give myeloablative regimen simply by fractionating to the older patients, and that does reduce non-relapse mortality. And this translated into better survival, 30% versus 50%. And so here is the second principle. Fractionation permits delivery of myeloablative dose to older patient and appears to reduce relapse without increasing non-relapse mortality. Can you do better? So if the long is better, we said, why not just move it even further out? So now you give a dose on day minus 20. And the day 0 is, of course, the day you give cells. You calculate the pharmacokinetic PKs and then you give the rest of the dose so that the total course exposure is area under the curve, 20,000. We also started using post-transplant cyclophosphamide to further reduce non-relapse mortality in this group. And this then was the candidate for this study were patients who needed reduced intensity transplant. And what we see here is 3-year non-relapse mortality, 9%. Median age here was 61, and we enrolled patient as old as 70. And then NRM did not differ by age or comorbidity. So again, this resulted in even better non-relapse mortality after using post-transplant Cy and longer regimen. And this leads to the conclusion that the further fractionation reduces toxicity and non-relapse mortality. And now, because you have this platform, you can add another drug to it. You can add 5-tepa because the NRM is significantly low. So we added 2 doses of thiotepa, and as you can see, very low relapse rate. Alternatively, you can add cladribine, which is a very effective drug in AML patients, and venetoclax more recently. And as you can see over here in this pilot study, we saw relapse rate go down to 13%. These are our average patients. So this then becomes our new fractionated regimen where you have these 5 drugs, fludarabine, busulfan, cladribine, thiotepa, and venetoclax go on. Because the longer regimen allows you to give a drug like venetoclax over a longer 20-day period, which is not available to you when you give short regimen. And what is so interesting is that this regimen is even more intense than fludarabine and busulfan because it has these additional agents, including cyclophosphamide, which is given post-transplant, or even bucy. So this is the most myeloablative of the regimen, and we are giving it to older patients. And the proof of this is, so the real question is, okay, we have added all these things. Does it do any good? So we said, let's choose the patients who are at the highest risk of relapse and do a phase 2 study. So in this trial, which I just presented at last ASH meeting, the inclusion criteria were 18 to 70 years of age, any donor, matched or haploidentical. Patients had to have either active disease, primary refractory or relapse disease, or they were MRD positive or secondary AML, or MDS patients have high IPSS or very poor cytogenetics. So essentially, these were very high risk patient, and our expected relapse, expected progression-free survival was 30% in this cohort. And we said that 50 patients will give us a power to increase this to 47% with type 1 error rate of 5%. We enrolled 50 patients between 2021 and 2022. And objective was 1 year progression-free survival. And the idea was, can we beat this historic rate of 30%? So this was the cohort. So median age was 59. Half the patients were older because older patients are the ones who have this disease. We had 40% of the patients with active disease, either relapse or primary induction failure. EL and adverse risks was in 56% of the patients, and 68% of the patient MRD was positive. And again, the IPSS moderate high, or very high was in 80% of the patients. So these were very high risk MDS patients as well. TP53 was present in 22% of the patients. And here is the bottom line, 60% progression-free survival. So we were very excited with this data. Follow-up is quite substantial, 23 months. And therefore, we are taking this into a randomized trial to see if this. So this is one idea, how you reduce relapse rate, perhaps fractionate the regimen, give myeloablative regimen even to older patients, and add multiple agent with anti-leukemic activity. The relapse rate here was 16%. As you can see, we would have expected something like 60% relapse rate in this high-risk cohort of patients, and without much increase in non-relapse mortality. So further fractionation reduces toxicity and non-relapse mortality without increasing relapse rate, and you can add additional agents like cladribine, thiatepa, and venetoclax to reduce relapse. So I'll move from conditioning regimen to the other tool we have, and that is maintenance therapy. So the question of concept of maintenance therapy is, how does it work? So really it is, even after transplant, if you have small amount of disease that is remaining, which is what is causing the relapse, you hope that the maintenance therapy given over a year or 2 years would take care of that residual disease and prevent relapse, something like why we use maintenance in patients with ALL. I think the problem is there are going to be drug-to-drug interactions. So these patients are going to be on azoles. These patients are going on multiple treatment. Second, the patients will have a weak graft. You can get away with, say, giving azacitidine higher dose, say 50 milligram or 70 milligram per meter square, but you cannot get away with same sort of dose post-transplant. And finally, what do your drugs do to immune recovery and risk of GVHD? So there is a problem again of giving maintenance, as in it causes complications. I guess, again, you choose the patients who are at the highest risk. And we started this study, my colleague Marcos de Lima started this study way early in late 2000s. And in this pilot study, we gave patients with AML increasing doses of azacitidine. And we found that the maximum dose we could deliver was 32 milligrams per meter squared daily for 5 days. And the results were very promising, but this was uncontrolled trial. So similar data have been available with decitabine. You can give decitabine, and these days you can also use oral decitabine for 3 days and see improving outcomes. Again, these are uncontrolled trial. So we decided, okay, so this is what we have. Why don't we randomize the patient? So we did this randomized patient. We randomized 187 patients, allocating them to observation or control or to give azacitidine maintenance. And the bottom line was, and you can see the problem here in this particular block over here, 63 of the 93 patients who were supposed to receive maintenance had to discontinue it for one reason or the other, either because they relapse, either they couldn't tolerate it, either because of toxicity. So I think this was the first challenge. Giving drug to 100% of the patient is a challenge. And mind you, for enrollment, these patients had to be in remission and had to not have GVHD. The bottom line, the survival curves are overlapping. So this was very disappointing. Despite years worth of effort, we did not find any improvement in survival. So next step, is there anything else you can do? And so this is a study that was published by, this was a multi-center study, and they used this drug called APR-246. And they used it in a highest risk disease, TP53 mutated AML. This drug acts against TP53. And they did show relative reduction in the relapse rate, if you will. And they thought this data were promising. I think the problem is this is, again, an uncontrolled trial, and the company discontinued development. The relapse rate for TP53 disease of 38% was felt to be promising. Unfortunately, this drug is no longer being developed. So what about the latest magic drug, venetoclax? So aza-ven, we know in AML setting, is better than ven alone. And so we added venetoclax to azacitidine and came up with this, again, in uncontrolled setting. This was phase 1/2 study, that relapse-free survival of 70%. So this appears promising, but needs to be tested in a randomized setting. Likewise, Dana-Farber used the same strategy. And again, the jury is out on this regimen. And at least today, in my clinic, if I have a patient who is at high risk of complication, high risk of relapse, we have a protocol. We do use azacitidine and venetoclax. We wait for the randomized trial to tell us whether this is really effective or not. But pending that, we are using this. So this is one approach. Other approach is oral decitabine, which is, again, relatively easier to deliver. That's the second thing we use in patients, because there was a question as to if you don't have a targetable mutation, what do you do? This is what we try in high-risk patient, aza-ven or decitabine. What about FLT3 inhibitors? And this was a second study, actually. This was a Chinese randomized trial where you can see substantial reduction in relapse rate with sorafenib. And this was also seen in this German trial. Again, significant difference, and sorafenib did reduce relapse rate and improved survival. And again, so for FLT3 patients, this has become one of the options. I think there was lot expected from this randomized trial of gilteritinib. This is a BMT-CTN morpho study where patients were randomized to gilteritinib or placebo after transplant. And I think in some ways the study was sort of equivocal. So there was a benefit, as you can see over here, but the p-value was 0.0518. So the purist would argue that this is not significant, although you can see the benefit over here. What is unquestioned, and this was pre-planned analysis, is that there is a difference in patients who are MRD positive. So again, if you have capability of doing MRD, if somebody is pre-transplant FLT3 MRD positive or even post-transplant positive, gilteritinib certainly improves survival or relapse-free survival in this case. What about IDH inhibitors? So there is some phase 2 data on ivosidenib and enacidenib. And again, this needs to be proven in a randomized setting, but in an odd patient who is at high risk with this disease, we would use these oral drugs because they are easy to give. So currently, there are no therapies approved for maintenance by FDA after allogeneic transplant. There are several randomized trials. UK group has completed several, and we eagerly await the results. And hopefully that would lead to give us some positive data about this strategy. FLT3 inhibitors and IDH inhibitors have shown safety, and there is some benefit, therapeutic efficacy of FLT3 inhibitors, as I showed you. And again, you can deliver azacitidine, decitabine, and you can even combine it with venetoclax. Again, it remains to be shown whether this strategy reduces relapse. Okay. So what about using cellular therapy instead of using drugs? Because transplant is the biggest cellular therapy. So, a reasonable question one could ask is, why not give donor lymphocyte infusion? And this is the largest study, and this is EBMT retrospective study. And this illustrates the problems and promises of this approach, if you will. So this study in 318 patients, 78% of patients had AML. This is the first problem. 2/3 of the patients had reduced intensity conditioning. And as you guys said, you don't use reduced intensity. So is this applicable to you? Certainly, you can use the principle used over here. Second, 84% of the patients had T-cell depleted transplant, either in vivo or ex vivo. And there weren't very many patients with PTCY, which a lot of us use these days. It was given for MRD positive post-transplant in 23 patients, mixed chimerism in 169, and prophylactic in 126. It was given at the median of 176 days, and it's worth looking at this paper if you are interested in this. But here is the summary. The dose given was heterogeneous, and what you see over here, 29% relapse rate was present. And so I don't know your relapse rate, but we see a 2-year relapse rate of 30% on average risk patients. So I'm not sure it is reducing it very much. NRM was 13% and PFS was 58%. 12%, and here is the problem. This is definitive. This patient, you can get graft versus host disease, 12% acute, and chronic GVHD in 32%. And there was 6% mortality because of DLI. So this is not a benign treatment. Again, risk factors for GVHD in this protocol included age, advanced stage, this is very important, interval from transplant to DLI. So longer the interval, more they can tolerate. Shorter the interval, less they can tolerate. And so more shorter the interval, higher the GVH. And somebody who has had prior GVHD, I'm not sure this strategy is worth using because you are at higher risk of GVHD. For what it is worth, they showed decrease in MRD and increase in full donor chimerism in 70%. You can't say anything about the prophylactic group because there is no control group. So this is the best data out there on this strategy. And with this data, EBMT came up with this guideline. You give it prophylactic for high-risk disease. Again, this is expert opinion. This is not necessarily based by data. Preemptive in patients who have mixed chimerism or MRD positive disease. The prerequisite, they would argue, is that you should give it after 98 days. Patient should not have infection or GVHD, or patient should not be on immunosuppression. So you should take him off immunosuppression. And you give escalating doses based on indication. And again, this paper kind of nicely describes this approach. And I would strongly recommend, if you're wanting to do DLI, please look into this Lancet Hematology paper. Can you do a more clever way? And this is one of the studies we have open nationally here and even at our sites. So looking at this figure, here is your patient, and these are cancer cells. And we all have this minor histocompatibility antigen. This is a difference in the peptide, which differ between me and my brother who is matching. So these are called HA1 or HA2 peptide, HA2 antigen. And what you do is, if a patient is HA1 positive, can you develop donor cells, again HA1, and give HA1 negative grafts? So here is the strategy. This is only used in haploidentical patients these days. So, and this is all, so here is the patient who is HLA-A2 positive, because this company can only manufacture these T cell receptors specific for HA1 and HA2 only with A2, if the recipient is A2 positive. Donor is either A2 negative and also negative for HA1 or HA2. And this donor cells you transduce with HA1 specific T cell receptors, so T cells that target HA1 or HA2. And post-transplant, you give this, and this, if you will, is a targeted DLI. It eradicates the residual cancer cells, which are going to have this HA1 antigen positive, and you can eliminate those cells and leave the HA1 negative cells, and thereby preventing relapse. This has been presented at multiple settings, and right now 26 patients have been enrolled in this trial. And what you see here, and this is again very early data, not very much follow-up, but what you certainly see is, compared to control arm, in the treatment arm, event-free survival is much better because the relapse rate is much lower. And there are several similar approaches. There's an approach in ALL where they give CAR T cells. There is an approach where they give gamma delta T cells to prevent relapse. And many of these exciting approaches are currently being studied to see if we are going to see any effect of these. So to conclude, relapse is a major cause of treatment failure. It's a problem in India. It's a problem in US as well. Risk factors for relapse are remission status and MRD. So if you can develop more effective induction therapy and get more patients into good remission, MRD negative, you can reduce relapse rate. You cannot do very much about high genetic risk subgroup, but we probably need more targeted therapy for those, particularly TP53. What strategies can you use to reduce relapse rate? One, you could use a myeloablative regimen, and I showed you an example. You can give PK-guided fractionated busulfan even to older patients to deliver dose intensity, because dose does matter. The alkylating agents have significant dose response relationship, and you can add additional non-cross toxic agent, and this synergy may further reduce relapse. And I showed you an example of that with our fractionated busulfan, cladribine, fludarabine, venetoclax, and thiotepa regimen. We call it CLADLAC regimen, and we are now testing this in randomized trial. And you can also use maintenance therapy. The best data is with FLT3 inhibitors. For non-targeted approaches, you could use azaven, although it has not been shown in randomized trial, or oral decitabine. And you could think about immunotherapy and some of the exciting CAR T related approach I showed you. Thank you.
Thank you, Dr. Popat, for that exhaustive lecture. You have covered the topic extremely well, starting from approaches pre-transplant to what are the modifications that can be done in conditioning regimen, to the post-transplant maintenance strategies, and the latest cellular therapies, DLI, CAR T, and so much more, which can be done post-transplant to reduce the relapse risk. That was a very, very structured way to deliver the talk, and your talk was quite exhaustive. We have a few questions from our Indian colleagues as well as from our colleagues at Fortis Gurgaon. So can we go ahead?
Sure.
So one of the best slides in your talk where you nicely showed how MRD positive patients are at high risk of relapse and how the curves nicely separate out in MRD positive versus negative patients. One of the questions which has come up in high-risk AML patients, especially the TP53 mutated patients, very often it becomes extremely difficult to get them to an MRD negative state. And even in our experience, we have tried in many patients where we have given additional treatment for MRD negativity, but patients ended up having a very quick morphological relapse while we were giving them further treatment. So my question is, which subset of AML patients would you take up for a transplant without waiting for making them MRD negative?
So it is always a challenge between what is feasible, which you rightly highlighted, because there are some patient, TP53 patient, you're never going to get them negative. If you get them in remission, you're lucky. If you keep giving treatment, the downside is they get infected. Either they may not reach to transplant, or if they reach to transplant, they may die of toxicity of transplant because they are so beaten down and infected. So that's the one side of it. And the other side of it is the data that I showed you, that you don't need them MRD negative. And in days gone by, we have a system where treatment is given by a leukemia doctor and we do transplants. We are in a lucky position. So we'll tell them, if you can't get them into MRD negative, we are not taking them, or if you can't get them in remission, we are not doing transplant. We realized that that wasn't the right thing, because a lot of patients who we could help, we didn't. And the best example of that comes from ASAS trial, and I should have put in the slide. And this, for those of you who don't know what this trial was, Germans did this studies where patient who got induction therapy and had persistent disease, or those who relapsed after being remission in induction therapy, they randomized them either to taking them straight to transplant with active disease. We're not even talking about MRD here.
Yes.
Versus giving them induction therapy and then later taking to transplant. And the beauty of this study was they didn't show any difference in outcomes. So then you could argue that your MRD is not a marker, or it is a marker of a biologically aggressive disease rather than a marker for that indicates that you need to treat this to change relapse. So, that brings up a very complete different thinking. So more and more, we are realizing the limitations of what we can achieve with induction therapy. And more, we are taking patients to transplant with early disease. The regimen that I showed you, it is very aggressive. And that is a go-to regimen for aggressive patient for patients who are not in remission. I mean, patients who are not in remission, you can't give reduced intensity flu-bu. They're going to relapse right through. Even patient in remission relapse. So because we are fortunate to have that kind of a regimen, that's what we use. We have another program right now where we call quote unquote rapid transplant. So we see the patient when, say, TP53 AML is diagnosed. Our goal is to take them to transplant after 1 or 2 courses, irrespective of the disease status, using the ideas that I told you. I don't know how effective that is going to be, but as they say, watch this space. So we'll see if that strategy works, but it is difficult.
And how much of a difference does the type of induction therapy matter? Like a couple of years back at ASH, there was a presentation where they basically, what they tried to say was, regardless of how we get patients into an MRD negative status, be it AZA-ven, be it FLAG-ven, be it FLAG-IDA-ven, the outcomes do not matter as long as we are getting them into an MRD negative state. So this threw up a couple of questions for us. We have elderly patients and sometimes even young fit patients who come in with infections and pneumonia. We start them on azacitidine and venetoclax if they are not, even young patients who are not fit for intensive treatment. And by the time we finish 1 or 2 cycles, many of them achieve a very good response, and few of them do get into an MRD negative state. So very often we are confronted with this question: should we take them directly for a transplant? Should we give them an anthracycline containing regimen, or should we give them 1 dose of high dose cytarabine before we take them for a transplant? So how would you approach this? If patients are in a deep response, or best case scenario, MRD negative post 2 or 3 cycles of a reduced intensity treatment, would you consolidate with a transplant, or would you give them more intensive treatment prior to transplant?
So this again is based on personal philosophy and personal experience, because there's not much data to go by. If you'd asked me this 5 years or 10 years ago, and I was still doing transplant then, I would have said, no, give them 1 more treatment. Lately, I take them to transplant as soon as I can, irrespective of. Now, so we are, say, 10, 15 colleagues. Each of one is at a different spectrum. So I'm one of the ones, and a lot of people are moving towards in my direction. We just take them. And remember, the advantage we have is even our 70, 72-year-old, we are giving this myeloablative regimen. So we believe that with a myeloablative regimen, we could take care of this residual disease. And number 2, we will try and give them maintenance. Although giving maintenance is very hard, but we will. And hopefully that will help them. Because we have tried the other way.
Yeah.
Okay. So we have tried giving additional doses of chemotherapy. So if person goes into remission after additional dose of chemotherapy, that's your best outcome. But out of 100 patients you take, that is going to happen in 10 or 15 patients. The remaining are either going to be same place as they are, or they're going to be worse off, or some of them are going to get infection, or you lose some patients in the process.
Absolutely. I mean,
And so, yeah. And so I think that is a challenge. Nobody has an answer, but that's my approach, right or wrong.
Right. And I think the same would probably apply regarding what is the induction regimen, because right now we have shifted most of our patients to a flag venetoclax regimen. And maybe a few years back, patients were uniformly receiving a 3+7 induction. But we have seen a lot of morbidity, prolonged hospital stay with 3+7, and we have shifted to a flag venetoclax. And very often the criticism which comes up is avoiding anthracyclines may increase the relapse risk. So is that true in your experience as well? As far as induction regimen is concerned, do you think anthracycline should be a definitive part of AML induction, or can we get away with regimens like flag venetoclax?
I think that's not a wrong idea. Let me put it this way. And why do I say that? So in our setting, our younger patient and by young we mean less than 60, we will give one of our flag type regimens. So either it is flag IDA with venetoclax, or it is cladribine, CLIA IDA with venetoclax. And then those papers are published, if you will see. In younger patient, that is a go-to approach who are fit and healthy. The problem with either of those is the patients end up with long neutropenia, and it takes time for them to recover.
Yes.
You're right about that. But patients older than 60, most of them get aza-ven plus or minus something else, right?
Yes.
Or our second go-to regimen, and this I think is probably one of the very good regimen, that is cladribine low-dose RAC and venetoclax. You should look up Tapan Kadia's paper in Lancet Heme, or even I think the recent one he did in JCO. That's a beautiful regimen. And so either that or aza-ven. So, and those patients, if we get into some kind of disease control, we take them to transplant, they're doing equally well. So I think you do what in your setting you are more comfortable and you have less toxicity and better outcome. And compensate it in the next chemotherapy or transplant chemotherapy phase.
And very often, and this is true, especially in relapse patients, where despite multiple lines of treatment, we are not able to get them into even a morphological remission. And I think the paper you highlighted, where they took up patients with active disease for transplant versus try to give further treatment to get the disease bulk, would hold good in that setting. But few of our patients, especially patients who have received almost all the conventional treatments, we have been able to get them into remission with a regimen containing cladribine, cyclophosphamide, etoposide. And such patients, we usually get them into a hypocellular marrow, let's day 14, day 15. And without waiting for count recovery, we have taken many of these patients up for our transplant. So start the treatment at day 15, we do a marrow mainly to document hypocellularity and take them for a sequential transplant. So do you consider any patients in your practice for such a approach for a sequential transplant versus waiting for a count recovery and then taking up for a transplant?
So when it's funny when I mentioned this, we have this leukemia service. So when I said I want this people leukemia free, so in days gone by, what they would do is exactly what you're saying. I said, fine, I'll give them chemotherapy. Here I do the bone marrow at day 14, and now take them to transplant. These patients don't have. And we did a lot of that, and we still do a lot of that. The problem, there are two challenges here, in which I'm sure you're facing it as well. Number one, aplastic phase is not the same as remission phase.
Right.
So there are studies that show that you take patients who are in remission with count recovery, compare that to patients who are in remission without count recovery. Now, these are not even aplastic patients. You just have the count. There's a difference. And you take patients, this is the next level, you take patient in aplastic phase.
Yes.
Yes, you can do the transplant. Uh, uh, I, it's like a fig leaf. So you're not seeing the disease, you say 0% blast, but at a MRD level, there are some cells that are hiding there. So we do it, all of us do it, because you have patient who is refractory. What are you going to do? And the problem is the results are equally bad when you do this.
So
At
it's
least in
almost
our
as
case.
good as, taking patients up when they have active disease.
Yeah, exactly. So then why not take them into active disease
Rather
when at
giving
least they
them-
are not infected?
True.
And you don't have the cumulative toxicity of your induction plus transplant regimen.
Absolutely, absolutely. I think Jayestu is also there. Dr. Jayestu Senapati is also joined in. Probably he would be on the other side where he would be treating patients with a refractory disease. So, what's your take on that, Jayestu? If you can join in for a while.
Hi, Dr. Popat. Wonderful talk.
Hey.
I'm actually in India, and I will be going to Delhi also next week to meet Nikhil and Dr. Bhargav and others. Yeah, interesting time to be in India now.
I know. Be safe.
Yeah,
And
I
all
feel
of
for
you
my.
guys be safe.
Yeah, we will be on the better end, no doubt.
Yeah.
So, two questions, 2 points I'd like to make. One is the paper that Nikhil brought in about the MRD status, and whichever way we want to achieve it, the outcomes are similar post-transplant. That's actually by my colleague Alexandra Bazin and Dr. Ravandi, and we showed that the end matters, not the means. But we followed that up with a publication in Cancer, in which we actually looked at the clad-LDAC-Ven data, which Dr. Popat mentioned, and we are all familiar with it now, in older patients, more than 60 years of age, who were treated on this phase 2 trial and then subsequently underwent a transplant, and compared to patients who were treated with HMA-based therapy. And when we did a very strict propensity matching, we still saw that the clad-LDAC-Ven patients did better after transplant. We don't yet know why, but possibly the depth of remission was good, or we were selecting patients who were slightly better off to start with. But the survival curves were quite divergent despite all these patients receiving an allogeneic stem cell transplant, majority in MD Anderson. So that's one part. The second part to what Nikhil said is about the idarubicin. I think this is very contextual, depending on where you are treating the patient. Certainly, anthracyclines are associated with a lot of mucositis and toxicities, which I've had the option of seeing because I did significant part of my training in India. I did see a lot of Indian patients having toxicities to these anthracyclines, even at a very young age, which we don't see very commonly in patients who get Cleaven or Flagida-Ven, in our center. Anthracycline-free regimens like FLAG-Ven or CLAD-LDAC-Ven, which we call dual nucleoside analog regimens, they have shown really good data with respect to early count recovery while maintaining deep and higher rates of remissions, whether you choose an intensive arm like FLAG-Ven or a slightly lower intensity regimen like CLAD-LDAC-Ven. And I think in high induction mortality settings like India, 20 to 30% in some places, anthracycline-free regimens would be good, especially for those who would be followed up with an allogeneic stem cell transplantation. The third and the last point will be about TP53, and Dr. Popat knows because he's on both these papers. We did look at the outcomes of patients who underwent transplant at different time points. So the first was, all TP53 mutated AML. And when we looked at patients who underwent transplant at deeper states of remission, they did fare. They did better than those who were transplanted at not so deeper states of remission. But the problem is It's like a mirage. Sometimes to achieve those deeper states of remission, the patients never end up getting transplanted because they relapse or they succumb to infections, because TP53 mutated AML are known to have poor performance status, significant high organ comorbidities, even at the time of response. And we just showed that even among patients who are reasonably young, as per our transplant colleagues, like 70 years and low, durable remissions more than 2 months, so that we at least have a significant amount of time for the transplant process to be set up. So almost 3 months from diagnosis and 2 months from remission. Even amongst them, only 50% of TP53 mutated AML are being able to be transplanted, not for hindrances from the transplant side, but because of biological reasons. Either they have other malignancies, because a lot of them are therapy-related AMLs, or they have poor performance status, or they have secondary infections which just do not clear, even in some of them having count recovery. And that becomes a major challenge in TP53 mutated AML. So I think this rapid transplant program that Dr. Popat is leading would be really beneficial in these patients, so that the moment they reach some form of marrow remission or some significant blast reduction, we can take them to transplant. Thanks.
Thank
That's
you,
very,
Dr.
very
Very valuable
Yeah.
insights. Moving ahead, as far as the conditioning regimen is concerned, at our center, and I think at most centers in India, along with fludarabine, there are three other agents which are used. Either busulfan, which is the gold standard, and many centers, including the center where we trained, AIMS New Delhi, still follows the conventional flubu-4. At Fortis, we have switched to triosulfan to a large extent, mainly because of reduced toxicity, lesser hemorrhagic cystitis, and from a financial perspective, patients are able to have a relatively better post-transplant course. And there are many centers which use flu-mel-based regimens. So when we compare these three, and I don't know if there is a head-to-head trial, but do you think busulfan versus triosulfan versus melphalan, and at a myeloablative dose, there is a significant difference as far as the post-transplant relapse is concerned?
I don't know the answer, to be very truthful. So there are a lot of retrospective trials, and they don't answer the question because it depends on the patients you select. There is one randomized trial that the company did, but that is in reduced intensity setting. So between busulfan and triosulfan. I don't know of a randomized trial. And then the other issue is it IV busulfan or is it oral busulfan?
Yes.
Because in some of the European countries, they still use oral. Is it IV PK guided busulfan? So there are a lot of tweaking and variables there. So that's because now triosulfan is available in the US, and this question came up: should we adopt it? And we felt that we have fine-tuned busulfan with this IV pharmacokinetics, and now we have built this platform and added so much to it. It almost will have to reinvent the wheel again if we move to that. Now the question is, reduced intensity busulfan with fludarabine melphalan, is there any difference? So there are comparative trials. And the best of these are from CIBMTR group. And we have done these studies in various diseases. And there are some principles here. So this is comparing lower reduced intensity flu-bu with reduced intensity flu-mel, whether 100 or 140. Number one, flu-mel is usually more toxic, so NRM is higher. At the same time, flu-mel, the relapse rate is lower. Okay, so now you take a population of patients where, say, for example, AML, an average population, I think they don't show any difference because eventually it doesn't translate into any difference. you take the same thing in MDS patient, and MDS generally have a higher rate of relapse because of the genetic factors. What you see is that there is early dip in flu MEL curve, but eventually longer term flu MEL curve does better because the relapse rate is lower. So in that, you see a tiny difference in survival in favor of flu MEL. And you do myelofibrosis, the problem is reversed because there the NRM is a bigger problem rather than relapse. And there is a study that showed that flu-bu was better. So I think it is boiling down to what risk profile your patient has. And so for us, how we are using this data is if patient can tolerate our myeloablative regimen, all of them get it. If patient is so frail that they cannot get it, then we are using Flumel because we do have very high risk because being a referral center, we get lots of high risk patients.
Does the mutation profile of the patient in your practice make you decide a particular conditioning? Like other than the patients who you do with the fractionated busulfan, based on the mutation profile, do you alter your conditioning regimen?
We haven't done that. So if you were to ask Jess to, based on mutation profile, will you alter your conditioning or your induction therapy? He'll give you several examples. We haven't been as smart as them as yet or have figured it out. Jess, do you want to comment? He'll tell you how they use it differently as far as the induction goes. Jess,
So this with regard to intensive chemotherapy that for younger patients, usually our Cleaven and Flagydaven are very conserved regimens until and unless we see toxicity. But for the classical example here are CBF-AMLs. So in CBF-AMLs, for example, even in very older patients, we still use very intensive chemotherapy, and then for every decade of life, we reduce the dose by 25% beyond 60 years of age. I missed the first part of your question, Nikhil. Can you repeat?
So if your patient has FLT3 positive disease, will you alter your induction?
Oh, certainly. Yeah. So amongst the intensively treated patients, the only mutation in which we actually alter the regimen would be FLT3 ITD, where instead of venetoclax, we would add gilteritinib as part of the frontline regimens. Whereas in older patients, we do a triplet of HMA with venetoclax and gilteritinib or quizartinib for FLT3 mutated patients. For all other mutations in intensively treated patients, we give Cleaven or Flagydaven. Certainly TP53 is a different question. We decide about intensive versus low intensity therapy. But for low intensity treated patients, if somebody has an IDH1, we would choose Astex-Ven ivosidenib. If there is an IDH2, we will choose Astex-Ven and acidenib and things like that. So certainly our regimens would significantly be altered if there are targetable mutations. In the low intensity regimens, for somebody where we are choosing a mutation agnostic therapy because they do not have anything targetable, then that would be Clad-LDAC-Ven, which has very affirmatively shown good results. And in younger patients would be Cleaven, provided there are no targetable mutations except for FLT3.
So in transplant setting, we are not as sophisticated as them. But for maintenance, we do. So obviously, FLT3 inhibitors will use FLT3. If patient with FLT3 mutated disease will use FLT3 inhibitors, and others will use azaven or decitabine.
And moving to the post-transplant phase, how do you monitor patients post-transplant? Like, what is the typical frequency of repeating a chimerism, a bone marrow examination? Do you do a flow MRD, molecular MRD, or do you do both flow and NGS MRD? So our typical practice is usually at 30 to 35 days post-transplant, we get a bone marrow examination with both a flow as well as NGS MRD. And at 60 days and 90 days post-transplant, we repeat the same along with a chimerism, lineage-specific chimerism. Further monitoring usually at 6 months and 1 year, and post 1 year, we usually don't serially repeat tests unless there is a clinical indication to do so. So what is your practice for post-transplant monitoring?
I think it's exactly similar. So at 30 days, they will do a marrow. There we'll do MRD, and now we have availability of highly sensitive FLT3 and NPM assays. So we'll do those as well. We do flow MRD as well at that point. And going further down, the next, we also do lineage specific chimerism. So all these things help us. Going down at 90 days, we'll repeat the same thing, and then 6 months and 1 year.
So it's a very similar practice. And
Yeah.
With Dr. Srinidhi from Molecular Hematology joining in, we have been doing more and more NGS MRD for our patients. And very often it throws up questions where we get a report and we really don't know whether to act on it. So we have recently had a patient, high-risk AML post-MUD transplant. NGS MRD was positive at 0.1%. Patient had IDH1 and a couple of other mutations. So my question is, do you act on an NGS MRD if it is positive post-transplant? Especially many patients with NPM1, IDH, we see the NPM1 going away, but the IDH or let's say ASXL1 and other mutations persisting. So at day 30, 60, when do you really decide that you have to act on an NGS MRD report?
So let me clarify. You're more advanced than us. We do not have NGS MRD except for FLT3 and NPM. We do regular NGS panel, but it's not by any stretch of imagination MRD. So we use flow in that setting. Looking at the data of NGS MRD, and this is, I think, the famous paper in New England Journal from WashU. And what they did show was any positive post-transplant translated into higher relapse rate. So if you have a positive NGS post-transplant, I think you probably would act. And we do in whatever limited setting we see it, even whether it is flow or a regular NGS panel, even with the lowest sensitivity than yours probably, or NPM or FLT3. Any positive post-transplant, we act.
So
Now there's one exception, and that is if these are DAT mutations. So DNMT3A, SXL1 or TET2. So those, yeah, go
if
ahead.
Dr. Srinidhi is around, if you
Yeah.
elaborate about our NGS MRD techniques.
So, hello, sir. Good evening, and
Hi.
hi, sir. Amazing, amazing talk. So, what we've done is we've developed an error-corrected, highly sensitive NGS MRD panel where we go to a very, very deep level. My question here is that, I've had cases where the chimerism, the mixed lineage chimerism, I would say, or whole blood chimerism is 99% plus, but the patient had an NPM1, IDH1, and a DNMT3A to start with, and was treated with Azaven and then transplanted, and the NPM1 went away, but the IDH and DNMT3A persisted. So there is another school of thought now that except for the DTA, now it has been expanded to DTASI, like even the SRSF2 and IDH have also been included. But then it's, I don't know whether, if it's MRD or whether it's not MRD, because the guidelines are still not there and they're a little sketchy in that area. But I mean, I'm confident about my assay, that is for sure. I mean, I know it's there. I just know it. And, even if it's NRAS or, and we've seen NRAS, coming back as extramedullary disease. So it kind of throws up more questions and answers when I give out a report, and I feel, I'm always at the receiving end that what report have you given? And so what so now what I want to ask is whether should I call it positive, should I call it negative? And then I'll ask you another one which just struck me.
Yeah. So I think in your case, you are moving ahead of your clinical colleagues, unfortunately. Your essay is way ahead of them. So now it is incumbent on them to figure out what this assay means, or from the literature, if people have shown this data. I mean, you guys are fortunate to have this sensitive assay, NGS assays available. I think with time, this answer will become clear as to what is, whether it is just DAT, because right now, based on that study, we said DAT, but whether DAT, IDH, and SRSF2, will all those be in that group, or whether you wait, or what level? Because there's another argument that a very sensitive assay will detect a very low level of disease. Does that mean anything? And I think that we as clinicians need to sort it out. So, the next paper you guys can come up with what matters and what doesn't matter.
Right.
Because if you have the ability, even with 10 patients, and out of them with 8 relapse, then this is important enough.
So interestingly, this patient, NPM1, IDH1, DNMT3A, and I think one more SRSF2, transplanted, post-transplant, I think day 60, NPM1 went away, but IDH1 persisted at 0.15. And now then they actually ended up giving, acting on it. And today I reported it out as negative, and the IDH is totally gone. The IDH is gone. So probably that was MRD. I'm not sure, but then they acted on it clinically, and they were bold enough to act on it. But then, I mean, that is one. And the second question is, now supposing post transplant I detect a mutation in CBL or something, which is probably a donor derived chip. So
Yeah.
what would you do, and what is your take?
Yeah. So the second problem is very common.
Okay.
You end up with a mutation that was not present before,
Yeah.
and we just follow it. Don't do
Okay.
anything about it.
Okay.
If it is something new, we follow it. Now, your answer to your first question, if where you patient previously had IDH1 or 2, and now you are finding it, you have two options, right? One is to act upon it if you know surely that this portends relapse, or if you believe this other piece of data that you mentioned, that you add IDH to this DAT mutation as well, then what probably you can do is repeat a marrow in a month and see if it is still there.
Yeah.
And I think, and if you see rising level, or if you that may be a way to sort out this. But it is a learning curve as you go along, and maybe you guys will tell us what works best.
So we have had pretty bad experiences with NRAS mutation. Very often we have seen it coming as late as 1.5 years post-transplant. And in at least 3 or 4 patients, almost all of them have relapsed within 6 months. And we have 1.5 years post-transplant, more often than not, we would decide to follow up, and patients also would be very, very hesitant to take any further treatment. And we have seen patients relapsing as late as 2.5 years post-transplant. But the NRAS has preceded that, at least in a few patients. I don't know how significant it is, but like you rightly said, it's a learning curve.
Were these baseline NRAS mutated patients, or
Yes.
these you're
Yes.
saying? Yeah. So
They were
baseline
baseline.
mutation,
They had baseline NRAS.
a baseline NRAS coming back is trouble. For sure, there is a clone that's coming back, which could harbor the other mutations. This has been shown also. With or without transplant, certainly with transplant, you would expect the allogenic immune surveillance to delay the relapse, meaning as long as things have been fine. But an NRAS coming back, which was harbored in the past, is imminent relapse. A. And B, Srinidhi's question, sorry, I just interjected because there's something very close and we just analyzed this. NPM1 with IDH1. What was the VAF on the IDH1?
To begin with?
No, at the time point that you deciphered when other mutations were not post-transplant.
0.2, and once
Correct.
it was, yeah.
So when you say 0.2, 20% or 0.
No,
Or 2%?
0.2%.
0.2%. And this was the same IDH1 mutation that was there in the
Yes.
past,
Yes.
which had later become undetectable and now
Yes.
coming back. Yeah.
Yes.
So in such a patient, I would be very worried to not treat. So sometimes the NPM1, especially if they have secondary type mutations with or without IDH1, you have a lot of genomic instability. So even if the founder clone does not relapse, there are other clones that get survival advantage and relapse. This has been shown in the big UK NCRI trial,
Yes.
Jadotman, not trial, but the big analysis, in which they found actually that once NPM1 MRD is negative, if they had other mutations, especially secondary group mutations, their relapse-free survival was inferior because subsequent different clones can come up, which may or may not, which you shouldn't theoretically harbor NPM1 mutation.
Right. Right.
So we usually, meaning in the non-transplant setting, do act on these. I'm sure Dr. Popat would also have some thoughts.
Yeah. No, I think what you say makes sense, and um, yes, we would consider it very seriously.
And Dr. Popat, along the same lines, for the similar patients, once patients are off immunosuppression, 100% chimerism, we see a KRAS mutation coming in. How exactly would we act on it? Do you think we should give a DLI? Because what can be done at a late post-transplant stage for a mutation coming up? Or should we put them on an azaven?
I mean, you outlined both the options, right? So if you're worried about relapse, one or the other you would do, or you would do both, and give azaven and follow it up with DLI if you have the donor cell accessible.
We have few questions specifically from the audience.
So may I say something, because I have a
Yes.
meeting at 10-hour time in 2 minutes.
Oh, okay. Then I think we'll wind up and any further questions, I'll be happy to share it over mail.
Yeah.
So, I mean, we have already exceeded the time, an hour and a half. That's a really long time, but very interesting discussion, and I got to learn a lot from you. And thank you, Dr. Jayestu, also for chipping in and adding to the discussion. It was a wonderful discussion over the last hour and a half.
Yeah, no, I'm so sorry. I didn't realize it would go. There's otherwise I would not have kept the meeting at that time. But
No, that's all right. Actually, we have exceeded the time. We were planning
Yeah.
for an hour and 15 minutes, so it's already exceeded that.
Yeah.
So,
All right.
thank you.
Thank you
Doc.
so much. Thank you.
It was a
Thank you,
pleasure
Nikhil. Thank you,
listening
Dr.
to you.
Popat. Thank you, Srinidhi.
Thank you.
Thank you. Thank you, sir. Thank you so much.
I thank everyone, Dr. Srinidhi, Dr. Jayestu, Dr. Popat, for the wonderful discussion. And it just shows us how much more we have to learn and so many new things coming up. With Dr. Srinidhi around, NGS MRD, like she rightly stated, throws up more questions than answers. So a long way to go, but very, very interesting discussion with Jayestu and Dr. Popat. And I thank everyone for sparing your Friday evening and joining us for this Innovations in Hematology webinar series. And I also thank MCure for providing this platform over the last 1 year, for providing this platform for all the webinars that we have done over the last 1 year. I thank each and every one for joining in this Friday evening. We would come back to you next month with the Innovations in Hematology webinar series for a benign hematology topic, challenging clinical scenarios in therapeutic anticoagulation, where Dr. Khorana would be speaking to us on the 27th of June, 7 p.m. I thank you all for joining.
Thank you.